Hello everyone, my name is Peter Henderson and I'm Associate Professor of Surgery and Plastic Surgery at the Icahn School of Medicine at Mount Sinai in New York City and the head of the Henderson Breast Reconstruction team. I'm also the Director of Plastic Surgery Research, and I'm really excited today to be talking about stacked and bipedicled abdominal flaps for breast reconstruction. I have no relevant disclosures. And as a brief overview of what we'll be talking about, first we'll do an introduction where we define stacked and bipedicled flaps. Second, we'll talk about how the procedures are done. Third, we'll talk about what it looks like. Fourth, we'll show some outcomes. And finally, fifth, we'll give some takeaways. When someone is choosing to undergo tissue-based or autologous breast reconstruction, usually after a total mastectomy, there are fortunately many options of places on the body where the tissue can be moved from. That ranges from the back to the lower abdomen, to the top of the buttocks, the lower buttocks, and the thighs. For many reasons, the current gold standard in tissue-based reconstruction is the DIEP flap, deep inferior epigastric perforator flap. And those are all just terms that relate to the lower abdomen area. So that's the tissue that's normally removed in the cosmetic tummy tuck. But in this case, that same tissue gets to be removed and instead of being just discarded, is used in a very meaningful way to recreate a breast after it has needed to be removed for cancer reasons. This is a picture of the undersurface of a DIEP flap, a unipedicled DIEP flap, one that has one blood vessel pedicle. You can see the fat with the single vessel coming off of it. It's connected to the fat at about 3 different points. Those are where the perforators enter the tissue. And on the undersurface, on the back of the flap that you can't see right here, there is skin still connected to it. Like all free flap procedures, once the tissue has been completely disconnected from the body at the donor site, it is moved up to the chest where the artery is connected to an artery, as you can see on the bottom of those 2 vessels, and the vein is connected to the vein, as you can see on the top. This allows the blood flow to restart and the tissue to survive by getting good, healthy blood both into the flap and out of the flap. The amount of tissue that can be carried from that lower abdomen using the single pedicle is usually somewhere between 1/2 and 2/3, up to the level of the belly button and usually a little bit past. On this picture, you can see outlined in red the usual extent of tissue that is able to be adequately perfused. But what if one pedicle cannot provide enough tissue? What about the remainder of the flap that's not perfused by that one vascular pedicle? Here you can see the remainder colored in purple that in some cases would be very helpful to be able to use to complete the most adequate version of breast reconstruction. In some cases, there's not enough volume. In some cases, there's not enough projection. And in some cases, there's not enough skin. So one potential solution is what we call a bipedicled DIEP flap, or using that same area of tissue from the lower abdomen, but instead of only having one vascular pedicle, instead you dissect and include 2. And this usually allows you to include the entire extent of that tissue from hip to hip. And here's what one of those bipedicled DIEP flaps look like. As you can see, instead of just one vascular pedicle, there are 2. In terms of terminology, it can either be a conjoined bipedicled flap, as you can see on the screen left, where the 2 vascular pedicles are present and the tissue remains connected. And on the right, it's what some people refer to as a stacked flap, which is really 2 separate flaps, 2 pedicles, but each is independently perfusing a piece of tissue that is not connected to the other. Here's what it looks like when moved up to the chest. As you can see, it's a conjoined bipedicled flap. And then each pedicle is separately connected to a different set of recipient vessels. The purple pedicle is coming down and attaching into the antegrade internal mammary artery and vein, and the yellow pedicle is going down and plugging into the retrograde internal mammary artery and vein. Some of my colleagues here at Mount Sinai in the past published a great paper talking about exactly this sort of procedure. Now, there are certainly some vascular arrangements where this sort of procedure is more favorable and some where it's less. This is our flap map, the flap system that we've devised here at Mount Sinai that we use for preoperative planning for all of our patients. And the one on the screen left shows very simple, well-defined vascular anatomy with a single row of perforators that are easy to use and minimizes the degree of dissection necessary. And that's very favorable for doing something like a bipedicled flap. Whereas on the right, you can see it's a very distributed perforator pattern, would require much more intramuscular and muscular dissection. And I would perhaps think twice about using both sides of the hemiabdomen for a bipedicled flap for a unilateral reconstruction. Now, moving the tissue up to the chest is one part, but it's very important to then focus on the shaping and the inset. A recent paper from some of our colleagues in Australia and Europe published on exactly this question. And they showed a classification system showing all the different ways that you could manipulate that tissue by either folding it, dividing it, coning it, or some combination of all three. So there's, of course, a question of what it looks like. So here's an example of a patient who clearly needs a decent amount of volume to recreate the right breast once it needs to be removed for the treatment of cancer. And as you can see, after she underwent her total mastectomy on the right side, that did involve removing the nipple, we were able to recreate sufficient volume by using a bipedicled flap. This is a patient with a different body type, but does also need more volume than just 1/2 or 2/3 of her abdomen is able to provide. So a bipedicled flap was done in this patient as well. And as you can see, it provided a nice amount of volume that provided good symmetry. This is an example of a patient who clearly needs as much skin as we can possibly provide. This was also further complicated by the fact that she had a vertical scar on her lower abdomen. And so she clearly benefited from undergoing a bipedicled flap as well. And as you can see, she got a nice shape and volume. And ultimately a nice result, despite having undergone a pretty extreme initial mastectomy using a pattern that we don't commonly see. Our colleagues in North Carolina did a study where they looked at the outcomes of bipedicled versus unipedicled flaps for unilateral breast reconstruction. And they found that the complication rate between the two groups was the same. Interestingly, the operative time was also the same, so doing a bipedicled flap did not take any longer. And the main difference was in the number of times that a reduction was required on the other side, and that was decreased in the patients who had undergone bipedicled deep flaps. So by allowing you to get more volume, it decreased the need for patients to undergo a reduction in order to achieve symmetry. If the patient would like to undergo a reduction on the other side and wants to reconstruct of a size that matches that smaller reduced side, that's entirely up to her. But if she wants to maintain the same size, if possible, doing a bipedicled flap sometimes is the thing that allows you to do so. And some of our friends here in New York also looked at outcomes between stacked and non-stacked flaps. And they found that all complication rates were the same except for the amount of fat necrosis, which was less in the stacked flap group. And so that shows you that there's better perfusion, better blood flow, and most likely the greatest benefit was from greater venous outflow, which allows the flap to be healthier, have better blood flow, and the fat to survive in a way that maintains a soft, natural feel and appearance. So there are a few main takeaways that I'd like to share. The primary advantages are that bipedicled flaps allow for you to, if needed, use more tissue, which allows for greater volume, projection, or skin. It allows for less fat necrosis, and it uses the same abdominal skin that you would otherwise be using even if you were just doing a unipedicled flap. The disadvantages are that it does involve more fascial incisions because you're operating on and opening the fascia on both hemiabdomens, and that does at least somewhat increase the risk of a hernia or bulge, though those are fortunately very uncommon. And then it's possibly a longer operative time though as you can see, one of the studies showed that in many cases the operative time was actually exactly the same. So in conclusion, I'd like to put forth that bipedicled and stacked DIEP flaps can provide additional volume, projection, and skin in a manner that is safe, effective, and well tolerated. So again, my name is Peter Henderson. I'm at Mount Sinai in New York City. And if you are either a professional or a patient who'd like to discuss further, we're happy to speak with you about any of these. Thank you.